Good afternoon, everyone, and welcome to our UCSF Collaborative to Advise on Reopening Education Safely webinar series. This is the fifth session, and I wanted to tell you a little bit about UCSF Cares. We were a group of healthcare providers at UCSF who gathered starting over the summer and identified a mission to partner with our colleagues in education and public health to ensure a safe and ideal learning environment for children, teachers, staff, and the community during the COVID-19 pandemic. We've attempted to achieve this mission through highlighting the critical role schools play in support of our communities, using data to understand the safest ways to accomplish both in-person and remote learning, and to support equity through our guidance to give all children access to schools as a primary safety net in our communities. Through the month of August, we hosted 3 conversations on reopening schools during the pandemic, and then a 4th followed in September focused on preschools and childcare. Today's webinar is a follow-up to those earlier conversations to provide updates on what has changed and what hasn't changed since we last were together in the early fall. I am thrilled to bring back 3 of our speakers from the summer series to share information with you today and to hopefully answer some of those questions about where we are and where we may be going as well. I'm Elizabeth Rogers, and I'm a neonatologist with UCSF Benioff Children's Hospitals. I'm thrilled to be joined today by Dr. Lee Atkinson McAvoy, who is the Vice Chair and Executive Medical Director for Pediatric Primary Care and Population Health at UCSF Department of Pediatrics. Also by Dr. Naomi Bartek, Associate Professor and Vice Chair for Health Services Research at UCSF in the Department of Pediatrics. And finally, Dr. Emily Frank, who's a pediatrician with the UCSF Benioff Children's Hospitals and is a health teacher at Life Academy in the Oakland Unified School District. We'll be starting our session today with Dr. Atkinson McAvoy.
Thank you, Dr. Rogers. I'm going to start us off by sort of framing how we at UCSF really thought about our role. Next slide. So in 2009, when we had the H1N1 pandemic, the WHO guidance document stated this: there's greater understanding that pandemic preparedness requires the involvement of not only the health sector, but also the whole society. And we've seen this to be true as the COVID-19 pandemic has unfolded. Next slide. So our approach to think about it, that we are part of the health sector, but many of us either have spouses, partners, our own individual families, our connections in the community to realize that it's coordination of the health sector, but other sectors, government, education, industry, and then you as our community, we all need to partner and to communicate and plan and coordinate in order for us to best address the pandemic and best result in the outcomes that we desire. And for these webinars, we've been focused on education. Next slide. So UCSF has seen itself as partner. When we started the collaborative, we started it because many of us were reached out to individually as physicians, as parents, as parts of school boards to give our opinion on what we thought needed to happen for education. But that didn't only happen in the realm of education. It happened in the realm of research and scientists. And I just want to highlight a number of ways that UCSF has functioned as a partner. For government and public leadership, UCSF has been engaged with the California governor, mayors of San Francisco and city councils, as well as other local cities. Nationally, we provided expertise to the California congressional delegation and helped to inform the federal response as part of the task force recently named by President-elect Biden. As a healthcare system, we've partnered with other hospitals in San Francisco, as well as the entire UC Health campuses across the state of California to share best practices, to share resources, including at times when PPE was scarce, to leverage any excess that we had to support others. Our scientists have sought to study the virus, develop treatment protocols, novel treatments, and really participate in activities such as tracking and tracing, and really trying to understand the determinants of outcomes of patients who've been infected and affected by COVID. And finally, recognizing that education and schools are a critical part of our society, not just K through 12 education, but at the college level and the preschool level. We've really partnered with a number of school districts, and we formed the Collaborative on Reopening Education Safely. Next slide. Some other specific examples. We deployed physicians to work with public health to address outbreaks in San Quentin and other hotspots in the state. We've shared PPE to physicians' offices, as well as access to testing. We've provided education and expertise to other physicians. And we've ensured that we have the best practices on our campus to serve as a role model for our local community on how best we can safely allow patients to be seen and employees to come to work. Next slide. But despite all of this, we still see the ongoing impacts of the pandemic. And our decision to hold another webinar was based upon the fact that as of yesterday, California had accumulated over 1.25 million cases and over 19,000 deaths. We also know, looking at US Census data, that COVID in particular has had a number of impacts, from people being laid off, their job availability being impacted because their place of employment is no longer open due to either shutdowns or enough of their staff workers being ill, the individual workers being ill or caring for somebody who is ill, and then caretaking for the elderly and children. But what was most striking when we looked at the data, that 10% of people who were unable to work, not due to retirement, so we took out the folks who had retired, were unable to work because they had to care for a child. So COVID is really impacting all of us in a tremendous way. And when we looked at some data on education, families sort of responding, they noted that their child was spending less time on education. We know that teachers and schools provide expertise that many of us as parents don't possess. And we worry about the future sort of attainment of knowledge and expertise and development for our children. So the goals of our CARES organization is to really think about these data and these ideas and what can we do to help safely open schools and provide as much impact to our broader community. Next slide. And now Dr. Bardak is going to review the evidence around where are we now to help lead us in the next part of our discussion.
Thank you, Dr. Atkinson-McAvoy. Next slide, please. So for those of you who have heard me speak maybe in the first webinar, there's this disclosure slide I always still feel compelled to give, which is to say that I wear several hats. I'm a pediatrician and a parent, so I care a lot about school reopening for the sake of the kids who really need it, as Dr. Atkinson-McAvoy just outlined. But I'm also a doctor and a health policy researcher, which means that I also think broadly about public health, and I'm thinking about the adults, the teachers in the schools, and the family members at home. And so the most important thing is to say we have to get this right. And so my approach to all of this discussion of the evidence and thinking about where we are and thinking about policy is to try and get it right for everybody. So there's multiple hats on. And then the other disclosure is the COVID-19 landscape is constantly changing. So what we say today, there's
always going to be some kind of earthquake, although the data does seem to be getting relatively consistent about transmission, which I'll go over in a minute. And then lastly, it's a team sport requiring unprecedented levels of collaboration. We cannot do this alone. It's a theme that will come up throughout this presentation. Next slide, please. So this is a graphic of how the cases have trended over time since the beginning of the pandemic. And I show it to sort of think through the emotional and intellectual journey that we've gone through. Stage one in the very beginning, schools shut down. We said it's like kids are viral vectors. They're going to pass around like mad. Very obvious that schools should shut down. Then in May and June, we had flattened the curve in San Francisco. We felt like, okay, looks like we're going to be okay. Schools are probably going to be able to reopen. They've done in other countries. And then we went through a really big surge in July, and people got quite nervous, and understandably quite nervous. And the data on transmission still looked like it was probably okay, but it was hard to feel confident. And so there was a pause on sort of school reopening, and then again our numbers went down, and there was a feeling like, okay, maybe we can actually do this. PH put in a process. Schools did start to go through that application process and reopen. And we're now again in a big surge, and it's challenging for everybody to be in this big surge. And I want to really acknowledge that right now in particular, we're looking like at a state level and even locally, there's real worry about our hospital beds, and that whole idea of flatten the curve. Like we're worried that we're not successfully flattening the curve and we're going to run out of ICU beds and hospital beds. This conversation in that context might feel a little bit weird that we're even talking about schools, but we learned in the summertime that if we don't continue, and in the fall, if we don't continue to think through the operationalization and setting things up so that when numbers go down to make it safe to reopen, that we're going to be stuck without being able to sort of get kids back into the most meaningful educational environment that we can. So that's why it's still probably important for us to be talking about this, even as we're in the dark days of the pandemic right now. Next slide. So our goal for today is to provide a framework for approaching the next stages. I also want to review the new evidence and also talk a little bit about the experience on the ground with the school reopening so far. Next slide. So this is a slide from Emily Oster's work, which is sort of an approach to thinking about reopening activities overall. And you can see over on the side with the in the red, the orange/yellow, and then green, what activities she suggests we think about reopening, or how we think about risk-benefit ratio of reopening things. So lower risk activities are way over in the red. Where you have parks, we know that they're relatively low risk and they're high benefit. So they get way over there. Even if there's a high case rate, it probably makes sense to still keep those things open. Outdoor dining, gatherings, gym, indoor dining, larger gatherings, and then indoor dining, 100% indoor dining, outdoor concerts. Those are as we move across that, much higher risk things. And so, you want to wait until your case rates are quite low so that you don't open things up when they're very high risk. So the real question is, where do schools fit? And some could argue that they fit much closer to that area of green. That's how we've sort of treated them in some ways. Like, we were opening up indoor dining, in the orange and yellow, and we hadn't yet opened up SFUSD. And some people would argue that they're so high benefit, and that the data suggests that certainly elementary schools are low risk, that they should be much closer to the outdoor dining park section. Next slide. But what I want to sort of help people wrap their brains around is that different people have different perspectives on this. So each stakeholder has a perspective, and there's a gradation of how individuals experience this. So some families might feel like it's high risk for their children to go back to school, maybe because of risk to other family members, even though they highly value school, and so they might not want their kids to go back. Some families are actually on the other side. They're very desperate. Their kids are suffering academically and socially with mental health issues, physical health. The family might need to go back to work. And so they might really feel like the risk is worth it, or they might not think that there is much risk. Some people think that they don't perceive that risk very much. And then some teachers might feel like it's too risky to their health or the people they live with, and so they don't want to go back. But some also see that data is showing that it's low risk, so they feel like it's probably okay, and they would very much like to go back because they find so much value in going back. So I think it's really important to remember that we probably need to build a system that allows for some flexibility, because it's not going to be a one-size-fits-all solution. And so we can't just try and shove one-size-fits-all into everybody's decision-making right now. Next slide. So I want to highlight again this idea about collaboration and working together. If you want to go quickly, go alone. If you want to go far, go together. Because what is the goal here for safe and successful schooling is to minimize the damage to our societies, communities, schools, and each individual from COVID-19. It's not that we have to say, oh, this is the right way to do it. Oh, this is the wrong way to do it. Let's get into fights. We know that COVID-19 is the problem. It's going to cause bad damage to multiple different parts of our society, and we want to minimize that as much as possible. And it will take unprecedented cooperation, and there's going to be a lot of complexity and nuance. But we have to do it as a full society. We can't be, I'm a closer, you're an opener, you know, factioning and fighting around things. Next slide, please. So now just a little bit more about the evidence. So I want to refer, there's a couple of questions in the Q&A asking about a lot of evidence around transmission. I didn't, in this talk, because we covered it in the CARES webinar earlier, that transmission evidence hasn't changed a lot. So I want to just refer people to that talk. And I'll go over some new stuff, but there's more in that older talk also to answer some of those questions. But overall, the new data are relatively consistent with prior evidence. We know that school closure is associated with harms to children and families overall, and also leads to like deepening disparities. And that's true even from a very recent report that came out about school scores for how kids are performing. We also know that transmission between and from school-age children continues to appear to occur less frequently than in adults, with most cases as adult-to-adult transmission or adult-to-child. It's extremely rare to have transmissions in the school if mitigation layers are in place. And then there's one new piece of data that is relatively well done, and I'm going to go over just two or three studies now, which is an additional explanation why cases in children are less common. Next slide, please. So this is the study about why cases in children are less common. Why are they less likely to get COVID-19? If you might be familiar with the discussion about ACE2 receptors, the doorways into the body, and children make less of those. That's an understanding that we've had now since probably April or May. But the antibody story is a new one. So this is a very recent study that came out of Science. It was a study looking at antibodies of uninfected subjects versus infected subjects, meaning those infected with COVID-19. And some uninfected subjects, even before COVID-19 ever showed up on the scene, had neutralizing antibodies to something called the S2 spike, which is the picture in blue, the part in blue on this picture of the virus, which basically means that it's able to actually latch on to that part of the virus and destroy it. And it turns out that that S2 spike piece is very similar to other cough and cold viruses, also known as coronaviruses. And they found that, so it means that bodies that have never been exposed to SARS-CoV-2, the virus that causes COVID-19, can respond to SARS-CoV-2 with that antibody to the S2 spike. And it turns out that kids actually tend to have that S2 spike much more frequently than adults do. So that last little bullet point of 21 of 48 children have that S2 spike antibody, and only 1 of 43 young adults. And the theory there is that it's probably because kids have coughs and colds more often, and that immunity, that ability to fight that off, it can go away over time, but kids have it sort of ramped up because they're just always kind of getting sick. Next slide, please. So the implication is that the decreased infections of children may reflect additional protection due to that cross-reactive immunity from other human coronaviruses, aka the things that cause coughs and colds. Next slide. The other study that I've been finding helpful in terms of thinking about how to mitigate the effects of COVID-19 in schools is a study that came out of Berkeley that's depicted here. The sort of take-home point is depicted in a figure where they basically looked at across the bottom. You can see the x-axis says the proportion of each group experiencing symptomatic illness over the fall semester. They did, this is a modeling study. They basically said in the teachers or the students and household members, if you did no additional precautions, that's the very top line, how would that proportion of symptomatic illness change, or what would it look like? If you did no additional precautions, you can see that high school, middle school, elementary school, there's going to be a fair proportion of symptomatic illness we very, very much want to avoid. We would not want that to happen. And then it goes step by step on the y-axis over on the side, monthly testing of teachers, monthly testing of teachers and students, even weekly testing of teachers and students. You can see that makes a pretty decent difference. When you get down to weekly testing of teachers and students, you have, those lines have moved over a fair amount for all age groups. Interestingly, if you go down to the masks section, that is masks without anything else. It's masks alone. And they found that that actually moves things more than even the weekly testing of teachers and students. And then stable cohorts, even also alone, do more than testing of weekly testing of teachers and students. And then if you combine the strategies, it's a very, very powerful effect, getting us down to almost zero. So the implications are that masks and stable cohorts alone are associated with that decreased risk, even more so than the weekly testing of teachers and students. Next slide, please. The other helpful study that is a nice study that was done in MMWR that looked at the question of where are we getting COVID. They looked at people who had positive tests. They looked at people with negative tests, and they asked this question of what exposures have you had in both groups? And they found that you can see those two blue lines. You can see there's blue lines. If the blue lines are all the way 100% completely away from that dotted black line, it means that there was an increased risk associated with that activity. And the red arrows show us that it's restaurants are associated with an increased risk of getting COVID-19, and then bars and coffee shops, particularly that paler blue line. So the strong association with having symptomatic COVID-19 is having a close contact with a COVID positive person, or locations offering on-site eating or drinking. Next slide, please. And this last one, one more forward. Yeah, thanks. Is there's a real question for people when we talk about going back to school about public transportation, and it does show that that there's no association. You see those lines are going all the way across the black dotted line. There's no association with using public transportation and getting COVID-19. Next slide, please. So I was just going to go over some hot topics, testing and ventilation, which we get a lot of questions about. Next slide, please. So there's two ways of thinking about testing, three actually, because the first one is symptomatic testing, which if you have symptoms, the recommendation is go get tested. That's actually going to drive a fair amount of testing. The other kind of testing is asymptomatic testing, meaning you don't have any symptoms and everybody's getting tested at some kind of periodicity. And so the question is, when might we want to use testing for surveillance, and why would we want to use it? The New York City school experience, I think, is actually a really helpful case that case study that we now are able to learn from. They had 1,800 public schools open. They had about 50% of their students back in hybrid learning. They reopened and then they shut, but they also then started to do ongoing surveillance testing of their staff and a sample of students in every school, about 10 to 20% every month. And they found in the month of October, and you can find their updated data online, but they had 28 positives of 16,000 tests, 20 of which were in staff and 8 were in students. Very, 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 very low cases. That's 0.17% of cases. And that's just cases in the school-based population. That is not cases that got transmitted in schools. They don't even report that piece. It's just cases that are in the community, which is oftentimes they actually get infected in the home rather than in school. So as New York City was going up and down, they were able to actually see what was going on in their school community in contrast to what might be going on in their community with rising rates. And it was very helpful to understand what was happening for them as those rates are shifting. And that's in contrast to what happened in Boston when they had rising rates just a month or two ago, and they didn't know what was going on in schools. And so they shut down because they didn't have this ongoing surveillance. Next slide, please. So it's just that the surveillance is extremely important. California has actually given this recommendation. The state level recommendation is to do ongoing testing of teachers, not students, but teachers, because we know adult-to-adult transmission is much more likely. It's about 4 times more likely than kid passing it either to an adult or to another kid, especially in elementary schools. So the recommendation is to do 25% of teachers every 2 weeks or 50% every month. So that you get all teachers tested every 2 months. And you can see this is data from Marin County, which is showing that they had, you can see their total enrollment, almost 40,000 people in schools, 90 schools were open. And the cumulative testing on the other side for COVID was 26 students and 6 staff, and only 1 suspected in-school transmission, which my understanding was actually 2 teachers sitting next to each other for many, many, many hours on Zoom and right next to each other. So next slide, please. And our experience in San Francisco is actually very similar to what you just saw in Marin. I just heard a brief update on that today. So just to summarize, the testing strategy as people think about it is to know that the mitigation strategies, meaning masking, physical distancing, small stable cohorts, hand hygiene, ventilation, symptom screening, and testing, those mitigation strategies are still highly effective even without frequent testing, the frequent asymptomatic testing. And it's probably really important for us to remember that it's better not to direct money to testing. Testing has a role, but it's probably better not to redirect money to a huge testing program that could be better used elsewhere, where money could be spent on this other mitigation strategies. We really don't want to mess up the masking part. We want to get that right, PPE, and then also to direct education to kids. We also know that symptom screening is going to lead to testing and catch cases because a lot of kids are going to look like they have COVID, and teachers, because COVID looks so much, coughs and colds, like of normal viruses that we have. And then the asymptomatic testing is for schools, for school adults in order to do surveillance and ongoing policy decision making. Should we stay closed? I mean, should we open or should we close? If we are open and community rates are going up and down, that data will really help drive, inform decisions. Next slide. So a couple upcoming testing challenges and opportunities. There's going to be, we do know there's going to be an increase in testing demand, meaning that there might be less available for a lot of schools. That I think the schools that have vendors set up, and SFUSD has a vendor contract already there, but there is going to be an ongoing surge. So those symptomatic testing might be harder to get. And I think it's important for us to just know that it's going to be harder to operate our schools when there's a lot of testing demand. So the surge is going to potentially sort of lead to that increased demand. CDC just put out guidance saying it's possible to shorten quarantines. Shorten your quarantine to 7 days. That's a typo. If testing is done at 7 days, so they could actually, you could really shorten your quarantine. Instead of the 14-day, you could do it as a 7-day quarantine. And then there's also a new state requirement for weekly healthcare worker testing. And those additional demands may really limit access to symptom-based testing to return to school and other contact tracing. Next slide, please. There are some opportunities, which are there new tests getting released. Dr. Diane Havler is doing some tests with this new point of care test called Binex Now. Very inexpensive compared to our usual RT-PCR, which is around $125 a test. And there's another even newer one, which is a self-administered home test where you can get the answer in your own home. That's not going to be available probably until March. Next slide. I did want to touch on ventilation very briefly because I'm running out of time, which I apologize. So this is, but it's a very nice slide, and you guys can look at it after we're done, which is looking at how to improve indoor air quality. A lot of people are thinking about how do we do the ventilation piece, and this is a credit to Dr. Sohail Sood and Dr. Lisa Patel, showing us that in order to improve indoor air quality, you can do one of these 4 categories: bring in fresh air, clean room air, remove indoor air, or condition it. That there's some things that require HVAC systems, but there's actually good interventions that are highlighted in blue here, which can actually help to improve your air quality quite a lot, that don't require a huge change to your HVAC system. Next slide. And then this is the same slide, but just highlighting with stars, which are the high yield and evidence-based interventions, some of which also overlap with those ones that don't require changing your whole HVAC system. Some schools are well equipped with good HVAC systems and they're able to do it, but some schools need to go to those other interventions as well. And if you're really not able to do it, and some of the public schools really are worried about this piece, there is a recommendation to bring the classrooms outside, and people are trying to be innovative about that. Next slide. So what is the way forward? I think it's important that we need to keep our eye on the prize. Even during surge, it's really important that we keep moving that planning forward so we don't miss that opportunity when prevalence decreases. We know that vaccines on the horizon, but they shouldn't be a reason to lose our laser focus on safe and successful schooling. And we need to start planning now to think about making up for educational losses. Even if we think, oh, the vaccine's coming, we're okay. Like we put our children into an educational hole and we got to help them get out of it. And we should start thinking about that now. And then lastly, and very importantly, opening cannot be done on the backs of the teachers and staff. So any advocacy efforts that people are making should be focusing on making sure that we ensure adequate resources for schools to reopen safely those that have not yet reopened. Next slide, please. And then to harken back to that initial Emily Oster and sort of the gradation of risk tolerance, we do need to build flexibility into the system for families and teachers. And this is a kind of a complex conversation, but I think that that's actually probably the most important way forward. And then the other very, very important thing to articulate is that school community building and school community trust is really important. So SFDPH required a health pledge for community safety that everybody who's reopening, every family is signing it, every teacher is signing it. And that pledge is actually, it's not just a paperwork. We really have to believe in it and help each other out with positive messaging around masking instead of, penalizing the kid who doesn't mask. You make it so that everybody is encouraged. You're doing a great job. Let's do a competition, blah, 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 all the things that we know how to do right. And then around, changing kid behavior, we should do those things, not penalize kids. Also expressing care for each other, compassion, and not contention. And particularly from families, I think teachers, as they watch the surge going right now, they need to really feel like we have their back. And so the commitment to not come to school with symptoms, minimizing high-risk behaviors, staffs, and then make sure that also school administrators give staff some support to not transmit by mistake when they're outside their classes and they've let down their guard and they're more relaxed. Like I said, positive reinforcement for masking, and then sharing with each other successes, both the stresses and the successes. Next slide. And that's it. We won't do question and answer now, but I will just I'll give one last plug that we're in this together. No one's smart enough or can process fast enough or hold all the perspectives at once to get it right. So for me, please feel free to send notes or comments. Thank you. I think we'll move on to Dr. Emily Frank.
Dr. Frank, it looks like you're on mute.
Classic mistake. You would think by all the Zoom classes I've done at this point, I wouldn't fall for that. Thank you so much, Dr. Bartuk. I always learn so much from listening to you speak. My name is Emily Frank. I'm a in a number of places, largely in the pediatric emergency departments and urgent care. I am also a health teacher at Life Academy, which is a public school in the Fruitvale neighborhood of Oakland. We are a middle school and a high school. And so today, what I wanted to do is share a bit of what I have learned and where I'm at right now as an educator, and what I think will be helpful going forward. Next slide, please. This is my classroom. The slide on the left shows January 2020. I have 32, I think I had 36 students in that class. You can see them in groups of 4 working together, collaborating, doing hands-on work. On the right is a picture of my classroom this past Monday. I have 31 students. They are black muted boxes. I have been wholly unsuccessful in getting them to turn their videos on, even with bribery for extra credit. I am never interrupted, and I am often asking, "Are you there? Are you there? Hello?" Many of my students have a portable Wi-Fi device lent to them from the school, but have 4 other siblings
咁好多時佢都要問，你係咪嗰
to
度？
use it at the same time. Many of them are supporting their younger siblings who are simultaneously in class or have childcare responsibilities when their parents are essential workers. Next slide, please. Educators are trying really, really hard, and this is really tough. On the left is a picture of me trying to run some after-school events, necessitating 3 devices, a set of headphones, and a whole lot of toggling back and forth. On the right side is my classroom. All of those supplies were grants that I wrote to be able to provide students with hands-on learning so that they can continue to have authentic, meaningful learning experiences. And our school has done a phenomenal job at arranging opportunities for students to pick up materials. But what I want to highlight is that distance learning is really challenging for students. It's really challenging for educators, and everybody, students, parents, and teachers alike, are trying really hard. Next slide, please. In the dialogue about school reopening, there's a lot of commentary from the medical community. There's a lot of commentary from parents and from teachers. And one of the things I felt was missing from the conversation is what students have to say about distance learning. So on Monday, I asked my students, 31 11th and 12th graders and 82 9th graders. I got a total of 78 responses, what their thoughts were about distance learning, because I think they're a really important part of the conversation. The first question I asked them was to use 1 to 3 words to describe how they felt about distance learning. And there's 2 things that I want you to take from this word cloud that I literally copy pasted from Excel into a word cloud website. One is, not every child hates distance learning. And there is a huge variety of how children feel about distance learning. You can see good and hate. You can see okay, stressed. You can see better, hard, fine, bored, well. Our students have many different experiences with distance learning. I do want to recognize that I teach high school, and the impact on elementary students and middle school students, I suspect, is more weighted towards challenge, but this is the data I have from my high school students. Next slide, please. I then asked students to write 1 to 3 sentences about how they felt about distance learning. And I again want to highlight the huge variety of responses. If someone from the webinar team would like to drop my raw data link into the chat, please feel free. One student says, "It's been okay. I've still been learning, but it just feels like I could be accomplishing more. I don't even have a math class, and that's one of my weakest points." Another said, "I hate it because it's so much more difficult to learn online when there isn't like in-person help." Another said, "I love it because I have more time to focus on strictly school." Another said, "I like it because I get more work done than in-person class. I think that's because I get everything in one place and I get reminders as well. It can get confusing sometimes, but eventually I understand." Next slide, please. Others say, I don't like distance learning because since I'm in a different environment, it's more difficult to focus and complete my work. There is more distractions at home and it is more stressful because of technical difficulties. And in contrast, another one said, I've had a very good experience with distance learning so far. Nothing ever went wrong besides a few times the internet would cut off. I think that means the server would be lacking and crashing. Overall, I enjoy distance learning way better. Next slide. So I show you those quotes just to illustrate how varied our students' experiences are with distance learning. I also asked my students, would you feel safe going back in January? Why or why not? And again, I got really divided answers. 52% of my students said no, 12% said it depends, and 34% said yes. I'm going to show you the variety in these answers as well. Next slide, please. Absolutely not. The entire nation is going into panic and it is going downhill. I would refuse going to in-person school as it would risk any families that have an elder living with them. I have asthma as well, so I feel extra threatened by COVID-19 since I felt what it feels like to almost die. No, I don't want to risk getting COVID, and if that means going back to school, then you'll bet that I'll be skipping school. Yes, 100% because I want to learn. In this data, I saw the full gamut of student responses. Next slide. I want to highlight for us the many roles of a school. I think many of us knew this viscerally in the past, but the pandemic has really sort of like ripped the top layer off and has been a powerful reminder that school is so much more than class and education. It is connection, it is learning, it is nutrition. Many of our students get 2/3 of their food from school. It is socialization. It is an access point for healthcare and wellness and mental health supports. It is community. It is physical activity. A school is so much more than a place to learn. And I think that one of the things that this pandemic has really unroofed is how incredibly important schools are for the health of our children, like the overall health of our children and our society as a whole. Next slide, please. So what we're seeing, we are seeing a lot of decreased engagement. That can be having a screen up and walking away, having a screen up and playing games, or not even making it onto Zoom class. I see a lot of students falling off. I see some of my top performers sliding tremendously. I've seen some of my mid-level performers essentially dropping out of school altogether. There are students, a few that I have not seen all year. We know our students have decreased learning. Our students have a shortened school day. I teach health for like the equivalent of 3 hours a week. And now I teach it 2 hours and 20 minutes per week for only half of the school year. There's been a tremendous increase in mental health needs. I'll show you some data that supports this in a minute, but anecdotally, we're seeing it as well. There is increased hunger amongst our students and our families. There's an increased need for basic supplies. Our school has been holding toiletry giveaways twice a month, and after each opportunity, our shelves are empty and we go back to trying to raise funds. And certainly with all of the above, you can imagine there's tremendous amounts of increased stress. And we know that it is harder to learn and thrive as a learner in periods of increased stress. Next slide, please. The data isn't just anecdotally seen by teachers. A couple pieces of concrete data that I wanted to share. In the emergency rooms at Benioff Children's Hospital, San Francisco and Oakland, we screen all teenagers for thoughts of self-harm and suicide, as well as suicidal ideation. And what this graph shows you is the progression of positive screens. An acute screen is I want to die, I want to kill myself right now. And a non-acute is, I have felt that way before. And you can see that since summer, there's been a significant increase in the number of positive screens that we've been seeing. Next slide, please. These are some trends from the Adolescent service at UCSF San Francisco, which serves primarily to take care of individuals with eating disorders. On the inpatient service, so young people who are medically unstable because of eating disorders, their daily number of patients has tripled. And for outpatient referrals, those numbers are also up significantly, as well as their number of like mental health referrals and ability to get patients in has been significantly, their referrals have gone up, but their ability to get patients in is less because mental health providers' schedules are so full. Next slide, please. So what is the path forward? I'm going to talk briefly about that because I realize my timer is about to go off. Next slide, please. So I want to highlight a couple differences between March 2020 and where we are now. I almost said November 21, November 2020, but we are now in December 2020. We have a significantly improved understanding of transmission. At the start of this epidemic, we were not sure how this virus spread. We now have a much clearer idea of what actions and the actual physiology of how this virus spreads between people. As Dr. Bardak discussed, we have a much better understanding of mitigating factors and the really critical role, for example, that masks play in minimizing transmission. We also have a better understanding about youth and transmission and how the pattern of transmission for youth is quite different than that in other populations. Next slide, please. So for success in reopening, I'm going to go over these very quickly because I think Dr. Bardak really addressed them, but adequate personal protective equipment is essential. Access to testing if someone is symptomatic or has a known exposure is essential. That needs to be free and independent of documentation status with a quick turnaround. Contact tracing and symptom screening are going to be essential. And the last thought I'd offer is that if we have if schools are able to have students COVID test and staff COVID test before opening and ensure negative testing before the start, while that's not 100% certain, it will certainly maximize our chances of success in staying open. Next slide. But we need more than that. This really needs to be a societal investment. As Dr. Bardak mentioned, we absolutely need safe practices at home. We need fidelity in keeping symptomatic or exposed kids home. And we really need to prioritize school over other gatherings. Societally, we need to shift our focus and energy into what it takes to make it safe for schools to reopen before we are worrying about opening other social venues if what we really truly value is our schools. At a state and federal level, we need operational support in the form of money, support staff so that we can have smaller cohorts, support for contact tracing and all the administrative efforts that these are going to take. We need support for educators. We need an expanded subpool. We need a COVID leave bank. We cannot dip into FMLA every time we have a runny nose. We need early vaccination for our educators, is my belief. And then absolutely we need expanded access to mental health services. Next slide. In conclusion, I wanted to leave us with a few principles for reopening success. We must create policies that make it easy to do the right thing, for people to stay home if they are symptomatic or have exposures. We must have plans for quick notification and targeted closure, and we must be able to pivot quickly. As Dr. Bardak pointed out, COVID is a rapidly evolving situation. Thank you.
Thank you so much to our three speakers. We could definitely go on for a long time, and I will absolutely refer many of you who had questions. We referred back to the previous webinars, and we've put the link to those webinars in the chat, so feel free to refer to those. I'll ask our three panelists to turn on their videos There are a lot of great questions coming in, and unfortunately, we're not going to get to all of them. But I want to start, Dr. Bartek, with you because there are a lot of questions around vaccines. And I think in particular, vaccine prioritization for teachers, number one, and number two, is there a sense of, oh, the vaccine's coming, and so will that sort of pause us in our efforts to reopen safely?
Mm-hmm. Yeah, no, really important questions. I will give credit to the National Academy of Sciences as well as the CDC and the immunization panel they came out with recommendations to prioritize teachers as almost the top tier of considered essential workers and in line for the vaccine. So that prioritization has already been stated. One recommendation was that they should be right below healthcare workers. The other recommendation was that they should be right below healthcare workers and then people with comorbidities or at risk of really severe disease. Some teachers, we know in California, there's about 50% of teachers, at least potentially closer to 60%, who have some kind of comorbidity that puts them at risk. So that there is a dedication to schooling, and a prioritization to schooling in that ordering of the vaccine distribution. So I think that's really good. I would still say, though, this idea that we still owe it to our kids and to our communities to move forward with school, being careful about being safe and opening and successfully reopening, because it's going to take a while for that vaccine to actually roll out, and some people will take it and some people won't take it. And so we really need to keep our eye on the prize. We can't just lean back and be like, oh, we're cool, we got vaccines. We got to keep moving forward as a community and stay focused on that.
Great, thank you so much.
Mm-hmm.
Dr. Frank, this question's for you, and I know you've thought about this. There are many questions around referring back to the modes of transmission and the fact that schools put a lot of emphasis on fomites, cleaning surfaces, and there are some other questions about kids touching their masks and putting masks down. But we've learned a lot more, and so can we let schools lighten up on some of the cleaning, fomites, and focus more on the other risk mitigation strategies?
Great question. We know that COVID is primarily spread through respiratory droplets. When we were trying to figure out what was going on, we had a lot of concern around contact transmission. And so I think there has been publicly a lot of energy around this concept of we deep clean every day. And this is really not what's causing COVID. What's causing COVID is droplets from an infected person getting into the eyes, nose, or mouth of an uninfected person. And so we would be much better served really focusing on masking, distancing, ventilation, and hand washing before we touch our face, as opposed to these really frequent deep cleans, which are very time consuming and honestly quite expensive as well. I think there are much better ways that we could spend that funding.
Thank you so much. Dr. Atkinson-McAvoy, it's cold season, and what are the guidelines? And it's complicated. People have a hard time figuring this out. I do too. As far as a child who has a runny nose, what should we be doing with them as regards figuring out their COVID risk?
So as COVID has continued to spread and we've continued to study it, we are actually seeing runny nose as a symptom that could be COVID. And even if it's not COVID, one of the things that we've learned is when you are sick, it causes folks to stay home. So one, we're saying, if you have a new runny nose, your child has a new runny nose, you should stay home and call your pediatrician. We have sort of algorithms to figure out your risk ahead of time. What's the likelihood this is the common cold versus COVID? You can test from the same swab, so it's not extra testing. The good news is the data so far in our flu season, normally Thanksgiving hits us and we're seeing an uptick in flu positivity rate. We're actually lower this year than we've been for the last several years. And so some of the quarantining, masking, staying home is working to give us a mild flu season. And we're hoping it'll give us a mild other respiratory viral season. But one of the best things you can do for your community around you is if you have a runny nose, stay home. Stay home till you're better.
Thank you. I'm trying to fit in as many as I can. Dr. Bartek, there are a lot of questions about how the US has chosen to approach school reopening versus European experience. I'm wondering if you can just comment briefly on the differences there.
Yeah, I think that the differences between the US and some European countries highlight, I think, sort of a reflection less about the data and interpretation of the data and a little bit more on sort of the values that people place on education. And for instance, England, even though they're going into a really intense lockdown, they're deciding to keep their elementary schools open because they feel like the risk is low enough and the benefit is so very important. They put the schools way over on that one side, the red side of that line that I showed. France is even more extreme. They, like about 2 months ago, there was a study there was a news article reporting that in France, even for elementary school kids who have COVID-19, they're allowed to go back to school. And that's because the French were like, doesn't seem to like pass around very much and from these elementary school kids, and it's really important they're in school and it's probably fine. So that's different than what we've done in the United States. I think those other countries are also, they have socialized medicine, they have a much stronger social safety net. So that's the other thing that I think is to highlight as a difference. It doesn't mean it's not possible here to do that, but I think that probably explains some of the differences. But it also explains that there's different ways of interpreting risk and different ways of deciding to make these decisions. They're policy-driven decisions that talk about prioritization and where our priorities are.
Great, thank you. I'm going to make 2 comments myself before I ask the last round of questions for you. There have been a lot of questions around testing, a lot of specific questions, and I know Dr. Bartek was trying to answer some of them in the text. I think it's clear that the next webinar needs to focus on testing, and so I've taken that to heart. We're not going to be able to answer them all live. We'll do our best to somehow disseminate some curated information about best practices for testing. And the second comment I want to make is a lot of people asking, how is UCSF partnering? I know Dr. Atkinson-McAvoy mentioned some of the things we're doing, but we are open and in active conversation with multiple school districts in the Bay Area, with our public health colleagues, and we're open for more interaction in any way that we can partner to help. And I hope we're getting beyond sort of, whether we reopen, understanding we're in a surge, how can we really just make this happen with folks? So there are a lot of questions about how are we doing that, but what I'll just say is we are open for getting in touch with everybody. So last question, and this I think is great. Since we last held this series in August, what is the one thing that each of you would say has changed the most, either for you, for your perspective on school reopening, in the data, et cetera? Let's start with Dr. Atkinson-McAvoy.
So I know there's a lot of comments around access to testing, but we've been testing many, many more children in California. If you look at the numbers, et cetera, we've actually opened up access to testing for children to have a better understanding of what their positivity rate, and we still hover around the same number across the US. It's around 12%. So not every child can cooperate to be tested. Not every adult can cooperate to be tested, but we definitely have a better sense of the prevalence amongst children.
Great. Dr. Bartek?
I'll say that I was a little disappointed. I think my lesson from the summertime actually is a little bit of disappointment that we didn't, we got a little complacent and we didn't keep on focusing on helping, and once we got through surge, to help make people feel like they had all the resources they needed to be able to open up for our most vulnerable kids. I did some crying on a bike ride home one day, and I still cry sometimes about it. But it also gives me hope that I think, we got to learn from our mistakes, and we will keep moving forward and trying not to make the same mistake.
Dr. Frank?
I think my biggest discovery since July is sort of the power of a classroom as a physical space, and how significant the digital divide is. I had not really thought of a classroom as an equalizing space, but now when I now that I've developed an understanding to some extent of the challenges my students face with digital technology and with making their home space into a learning space, it's really impacted my views and my approach.
Thank all three of you so much. And I appreciate your patience for those of you who stuck with us for just an extra few minutes so we could get those last words in. We're really grateful for all our colleagues who've joined us in thinking about these issues as part of our UCSF Cares collaborative. In particular, we've received such support for these webinars and for the structure of our group through the UCSF Office of Community and Government Relations and from the Department of Pediatrics. Please feel free to view our previous webinars. This webinar and the materials will be up on the same website soon enough, and we'll also be sending a link to that out to our registered participants. We are open for feedback about next topics. I've taken note of all your questions and comments. We really appreciate our partnership with you all in the community and open to grow and learn with you all. So thank you so much.